Hi and welcome to Physiotutors podcast episode 69 with Niek Vink. Niek is a physiotherapist from Utrecht, Netherlands, and a manager and a teacher at NTE, the National Training Center for Ultrasound. The training facility is part of the main company Physio International, a company selling ultrasound devices in the Netherlands. Niek has been a public speaker on countless international events, and today we will talk to him about the role of ultrasound in physiotherapy. Hi Niek, welcome to the podcast.
Thank you for having me.
Sure, it's great to talk to you after quite a while. I think it's been a while that we talked to each other. And to maybe set the stage, I'm starting really basic for our listeners out there. Can you tell us what is ultrasound and which structures can we see or can't we see on an ultrasound image?
Yeah, sure. But we all know ultrasound scanning, I think, from obstetrics, which is the scanning of the baby, where they place the probe on the belly and you see the child moving around. And with that, they use a convex probe, which is shaped in a convex shape. And with ultrasound for musculoskeletal applications, we use a linear probe, which is a straight probe. We do this for the purpose of having more resolution. So with that probe, you get a lot more resolution, which is a good thing. But the limitation of it is because it's not convex. It makes the image that you get pretty small, pretty narrow. So that's one thing that happens. And what the machine does. Basically, the probe sends out a signal, an ultrasound beam into the body. And then in the body, the different tissues there will reflect the sound back to the transducer, and that will create an image on your screen. It's a bit like a boat that floats on the ocean and sends out sonar beams to the bottom, and you can see an image of the bottom of the ocean. Yeah. So that's more or less what it's about. And the tissues you can see... But it's quite extensive, actually. You can see all the soft tissues that are accessible. So if they become very deep in the body, it's more difficult. But when they're superficial, so around 5 centimeters, you can pretty much see nerves, blood vessels, tendon, bone, all these kind of things. Yeah. Limitation of ultrasound is that it can see the bone, but it can only see the superficial layer of the bone, the cortical bone. Cannot look inside the bone. So that's a limitation.
Okay. Yeah, I think I remember this one from the day that we spent at your facility for the basic course back then. Yeah. And how does ultrasound compare to other imaging techniques like, for example, X-ray, MRI, and CT scan? I'm not a radiologist, so I don't know all the details, but I know some things. For instance, with an MRI, you get a complete overview, which is very nice because you can get a complete view of the whole upper leg, for instance. Meanwhile, with your ultrasound probe, like I said before, you only get a small keyhole view of the body. So sometimes I call the ultrasound probe the mini MRI. But you have to look through a keyhole into a room. And with an MRI, you see the whole room. There could be 20 people inside. But once you look through the keyhole, you might see nobody. And there could be 20 people inside, so it's important to move around with the probe. And as for more the technical part, MRI, for instance, is very good at contrast resolution, and ultrasound is very good at spatial resolution. Those are two different things. And in fact, ultrasound is superior with spatial resolution. And how do you translate this? For instance, maybe you've seen a tendon on an MRI image. Usually it's like a big, long, black structure, and you cannot see any bundles inside the tendon because it doesn't have the spatial resolution. Meanwhile, you use an ultrasound, you can see all the bundles. So in the bundle level, which is very small, you can see the details inside the tendon. Where MRI is superior is with the contrast resolution, and for instance with muscle tears, you can get a very clearly a higher signal within the MRI, and those you might miss some tears with ultrasound that you will see with MRI. So that is superior. And of course, looking inside the bone. Like I said before, ultrasound, you cannot look inside the bone. And X-ray and MRI, they can do this. Yeah. Oh, and the last thing good to say is that, of course, with ultrasound, you don't get any ionizing radiation. So that is, of course, a limitation. You expose your patients to radiation when you do the other modalities with ultrasound. That's not the case.
Yeah. My next question was, what are the advantages and disadvantages of ultrasound? I think one is probably costs when we look at CT scans or MRI scans in particular.
Yeah.
Can you talk to us about that? Yeah.
The cost, because the cost, of course, somebody has to do the scanning, so it's quite time consuming actually if you do a good ultrasound scan. Meanwhile, with an X-ray, it could be a bit quicker. But for the rest, the advantages that you have is that it's, of course, safe, like I said before. You can use it in acute injuries. So especially for acute injuries, you can, like after 2 or 3 days, you can see the size of a tear or how extensive the damage is to a tissue. You cannot see it on the same day. So sometimes you see on a football field, you see somebody running on the field with an ultrasound probe, sticking it on the player, trying to find if there's anything wrong. But because of the body needs some time to get some fluid around the area, some hematoma and stuff to see actually what's damaged. So in the very acute phase, it's not useful. After 2 or 3 days, it's very useful. And a unique thing about ultrasound is that it's dynamic. So that means that you can put the probe on, you can let the patient make any movement that you want, maybe to provoke symptoms, and try to find with your ultrasounds what's provoking the symptoms, though that can be a very difficult one, in my opinion, because it's very difficult to find actually the provoking moment and see exactly with ultrasound what's wrong. When I started with ultrasound, I thought I was going to see with all my patients where the clicks were coming from in the shoulder and where the impingement would be, all these kind of things. Yeah, it's limited. It's given a lot of attention, saying, you can do dynamic scanning as a physio. You combine it with your clinical findings and your tests, but it is somewhat limited. And what is very useful, I think, is the sono-palpation. So sono-palpation is when you take the probe, you ask the patient where does it hurt, and then you try to place pressure with the probe exactly on the place where the patient gives the pain, to try to get a correlation between what you see on the image and the complaint of the patient. So that's something. And you asked about the disadvantages.
Yeah.
The biggest one is the operator dependency. So with an MRI scan, usually people go into an MRI scanner, very protocolized, they sit in the same position. Meanwhile, with an ultrasound, like you saw on the course, a little bit of angulation of the probe can make a tendon disappear, for instance. So that can give you very wrong conclusions on what you see. So to learn the skill of ultrasound, you need quite some time, and you have to put in a lot of effort. And so that's a disadvantage. You cannot use it from day one and expect to get very high diagnostic accuracy, I think.
I had that question already prepared for later on, but now that you touched on this topic, I think we can just go ahead and discuss it. How many images do you think one should take for a specific area until he or she is proficient?
I love that question, and it's a difficult one. I had, for instance, when I just started teaching here at the training facility, I was still not very skillful. I was still learning. And I remember there was one physio sitting in the back of the group. He was sitting a bit backwards with his hands on his belly. And he said, my name is, John. I've been scanning for 15 years. I was one of the first one in the Netherlands. And I thought, wow, this guy is going to be amazing because he's been doing it for so long, so experienced. And he started scanning, and I had to help him just visualize the biceps tendon, which is, one of the basic first scans in a protocol. And I thought, how is this possible? This person has been doing it for so long.
So just using the criterion of somebody that scans a lot is not the only criterion. It's an important one, but it's not the only criterion. To give a more academical answer, they did some studies, and I like to use the study of Alavecchios from 2012, where he took 2 orthopedic surgeons, so there's 2 surgeons, both without any skills in ultrasound, no experience. They gave them a 3-day ultrasound course for the shoulder. They gave them a device in their orthopedic setting, and they made them scan all their own patients. And then what they did is that after every 5 patients, they checked their ultrasound findings with the MRI findings or the surgical findings, which would be the gold standard. And then they measured the amount of sensitivity and specificity using those gold standards for what they saw. And they looked specifically at the full thickness tears.
Yeah.
And what we saw, you can see the graphs in the paper. Maybe I can give it to you for the viewers or the listeners. And you saw that the sensitivity went up at around 50 scans. Their sensitivity went up pretty good. It was about 85%. So that means that pretty quickly you can get sensitive at excluding pathologies or excluding a tear. Where it's more difficult is when you get more specific. You know, if it's a tear, is it a partial tear? Is it degeneration? Or is it a full thickness tear? And they saw that around 100 scans, both of the surgeons reached levels above 90% sensitivity and specificity.
Okay.
Yeah. So then it must be 100 scans. But in physiotherapy practice, we don't have an MRI. We don't have a surgeon to help us with the learning curve. So within physiotherapy, I would say that you would use around 150 scans, get good supervision, get good feedback on your scans, and then at around 150 scans, you can make it. But that only depends on if you get feedback and not like John, my example, sitting in his clinic without any supervision. Yeah.
Yeah, I remember the day that we spent at your training center. It was a nice day. It was nice to get, or to talk about the basics of ultrasound. But it was also intriguing to learn how, challenging it can be. And I think by no means would we leave and think we'd be proficient in really scanning the 5 big tendons that we covered back then.
Yeah. That takes time and effort. Yeah.
Hey, all right. I want to get back to the order that I had for my questions. So we already covered the reliability one. How do ultrasound devices differ, and what sort of devices do you see in physio practices and in hospitals, for example, where they have like the high-end stuff?
Yeah, the difference used to be quite large, actually. And in the hospitals, you will mainly find in the radiology department only the cart-based systems, which are the big machines that make a lot of noise, with many probes attached to it. And in physiotherapy practice, that's also, you can find that also, I think, maybe around 30 to 40% of the clinics has a device like that. And then you have the laptop devices, which is usually shaped like a laptop, and it's a bit thicker, bit bigger, usually placed on a little cart. And those devices are very popular in physiotherapy clinics because you can pick it up, you can take it to another clinic, scan the patient in another place. But of course, when you make devices smaller, you get a little bit less quality in the image. But I have to say that if you look at the device that I learned it on 13 years ago, and what you can get nowadays, it's really, really good. And then, of course, the last couple of years, there's been a huge advancement in the handheld devices. So that's the ones that you can either use with a cable, you can connect it to your iPhone or to an iPad. Nowadays, they are even wireless. They are becoming pretty good, I have to say. In the last couple of years, there's been a huge advancement in the image quality. It's still a bit limited, but it's getting there.
Okay. So you'd say even for practice, a device that I can connect to my iPhone, you can get pretty decent imaging.
Yeah, I could work with it now in the clinic, but knowing the limitations of my device. So at some points I will say, okay, I don't get a good enough image. Now I cannot make a diagnosis. Well, you don't make a diagnosis using just the ultrasound, but you know what I mean. I cannot do a report. Yeah.
Okay. Yeah, interesting. And talking about prices, what are the price ranges if I was to own a practice and to buy a device?
You have listeners from all over the world. So I think prices in Europe and in the Netherlands might be a bit different than in other countries. But for a handheld device, you would have to think somewhere between 5,000 to 10,000 euros. When you go to a laptop device, you go more to 15,000 to 20,000 euros. And you go to one of those card-based systems, you usually go above 20,000. Yeah.
Okay. Yeah. So quite an investment for a practice.
Yes. Yeah.
Okay. And how is ultrasound used in physiotherapy, and what are its primary applications? And I think, we're probably talking mainly about the Netherlands here again, but I think you might have some experience maybe abroad as well.
Yeah. I wrote this down, so let me take this here because, for instance, what we do in the Netherlands mainly is doing musculoskeletal ultrasound. Which is, looking at tendons and bursas and things like this. But what it was used for first was called a RUSI, RUSI, which is rehabilitative ultrasound imaging, and that was for looking at, for instance, the transverse muscle in the trunk and the oblique muscles, and looking at how muscles contract. When they contract and things like this. You remember the big hype with the transverse abdominis?
Exactly, I was just about to say that,
Yeah, so then ultrasound became really hot within physiotherapy. And then now it's still being done, but more looking at the pelvic floor muscles. So we have courses for pelvic floor physiotherapists, and they look at the pelvic floor muscles and how they contract, and they can actually train. So you look at the image, you let the patient see the image, you tell them, which muscle you want them to contract. Sometimes they cannot feel it, but they can see on the image when they do the contraction in the right manner. Then they say, so this is the contraction. And then you train them using the image. Yeah. So that's the first thing. And in some countries, doing musculoskeletal ultrasound is very, very tricky, especially when, you're from Germany, I think. No, so it's very... based on hierarchy. The doctors are, you're not allowed, you don't have direct access, I think, in Germany, or do you?
No.
Yeah, so then once you start scanning, the referring doctors might say, I don't want you to use ultrasound. I'm not going to send my patients to you anymore. And so that's a difficult field to use. And in the Netherlands, we have direct access, and it has created a lot of possibilities for us to expand on it. And one I wanted to mention, in the Netherlands, I don't think it's being done yet, but in England, it's up and coming, and it's a lung ultrasound. So it's within critical care. They look at the lungs. So critical care physiotherapists, they learn, for instance, how to see free fluid going around the lungs, which could be, I don't know the details, but it could be life-threatening or a serious condition. And in Blackpool Hospital, there is Simon Hayward. He's really developing like a whole framework for it, and he's doing some nice work over there. Yeah, so that's a new and up and coming application.
Yeah, I think in the UK they even do the injections. The extended scope physios, they are allowed to do injections.
Yes,
is not the case here, I think, and that can of course also happen under or be ultrasound guided.
Yes.
Yeah.
Yeah, and here in the Netherlands.
Yeah. Oh. Go ahead.
Sorry, I was just going to say that we also use it sometimes for ultrasound guidance. Yeah, when you do needling, for instance, for dry needling or for electrolysis, things like this. Yeah.
Yeah, I think we had Baba Kani on about dry needling on a podcast, I think 4 episodes ago. So she also said that it was used for dry needling as a training tool mainly as well. So that was an interesting one. And how widely adopted is ultrasound in physio practices? And do you see it increasing?
Yeah, that depends very much, like I said, on the country and how things are organized. Here in the Netherlands, Margriet Kooijman did a study in 2020 where she specifically looked at a big sample of 1,000 physiotherapists in the Netherlands to see how prevalent it was. And she concluded that in 1 in 6 clinics was using ultrasound. Yeah, diagnostic ultrasound, not the treatment ultrasound.
Okay, that's more than 1 in that's 1 in 6. You said so 16%, 16.66. I think that's quite a bit.
Yeah, and that's in the Netherlands, and in Belgium, for instance, there is almost nobody using it. It's up and coming now at the moment, and in Germany, I think also nobody's really doing it. And you have to look at the innovation curve. Now in the Netherlands, for instance, we if you know the innovation curve, when we have the early adapters in the beginning, and then you have the early majority, and then you go over the bell curve, and then you have the late majority and the laggards that also start with ultrasound. And in the Netherlands, I think we already went over the peak. Meanwhile, in Belgium, for instance, they are still at the beginning. There's only the innovators doing it. Yeah.
Okay, interesting. I didn't expect that, to be honest, with Belgium. Yeah, Germany, of course. So it's no surprise here.
Also the hierarchy. And lack of direct access.
They have other problems in Germany than being able to do ultrasound scanning. Hey, and how about overseas? Do you have any figures on that?
No, to be honest, I know if you see the UK as overseas, I think it's quite similar to the Netherlands. I wouldn't know for certain. They did a study once. I remember a study, I think it was Jackie Whittaker, did a study, like a survey among physiotherapists around all over the world, looking at exactly this question, how many people are using ultrasound. I saw very high numbers in all kinds of crazy countries, and I thought, wow, how is that possible? And I think maybe they mixed the ultrasound device with the application for the treatment with the imaging modality. But I know there is a study out there, but I don't really think those numbers are correct. I think it's still up and coming in most countries. Yeah.
Okay. Moving on. What would you say are the benefits of using ultrasound in physiotherapy? I mean, we talked about the benefits of it as an imaging technique, and what are the particular benefits when used in a physiotherapy clinic?
It gives you more information about your patient. So that's one. If you can look inside the patient, you can see the structures. Whether that is useful or not, that depends, of course, on how this information is used and how the clinical reasoning is done. And very importantly, how is this translated to the patient? If all that is done in the right way, then it can have, I think, quite a lot of benefits. Because with this information, I think you can make, of course, a more accurate diagnosis. And probably one of the questions that will come up is about the change of the how does it change my treatment? Well, it can definitely change your diagnosis. So therefore, it can change your treatment. In that regard, it gives you more information. But if let's say if you're a very good clinician, you can have a very good differential diagnosis. You will be pretty accurate, I think, with most things. So the added benefit of an ultrasound will not be very high. It will make your post-test probability, if you want to look at it academically, it will make it just a tiny bit better. But I think the problem is with most physiotherapists that they are not so good at clinical reasoning and doing their, not most, that's not the right way to say it, but there's quite a few people that have difficulty doing a good differential diagnosis just based on anamnesis and prevalence numbers. If you ask physios, but what's the prevalence number of this, they don't know it. So, and then what happens in the clinics in the Netherlands is that usually 1 or 2 people in the clinic do the ultrasound, and then the colleague that is not as good as doing the diagnosis refers for a scan to this therapist with the ultrasound machine. And usually that's the person that's also a bit better at making the diagnosis, because you're doing a lot of scanning. You're also clinically reasoning a lot with the diagnosis. So let's say it's more like a diagnostic therapist, and that uses ultrasound as an added tool. And I think therefore there it can be really helpful.
Yeah, I think personally, my opinion is a lot of patients, they want, or they really long for an accurate diagnosis. And sometimes they don't get it. Sometimes there is just no structural diagnosis, or it's less important. And I think in these cases, I do have quite a couple of patients who would have loved an image to really reassure them and to really show them, like, look, it's not just my opinion or what I found, because I don't have any imaging device. It's trust my anamnesis and my examination, but here's the proof that this is exactly what I was talking about. So I think it can really add to reassurance in a lot of cases.
Yes, I agree. And a lot of the times the scan is just done to exclude things, because patients come in with the most strange ideas. You know, if you have a little bit of an overuse in a 30-year-old, you know you're not going to find anything structural with your ultrasound. So why do the ultrasound image? Well, you do it because this person thinks that there's all kinds of things wrong, and you can actually show them that nothing is really wrong. And then actually I try to even enhance a bit the placebo with my ultrasound. So for instance, if a patient comes in, and this is still very prevalent, I think, that patients think that, you know, there's an impingement, you know. One time I had a woman that thought that bone was going over bone. And I explained her, what's happening with your arm? Well, my bone is scratching over bone. Well, if that's her idea, when we do exercises in the in the clinic, and she has to do this, and she thinks that bone is scraping over bone, that's not a very good illness belief. So, but then I make what I call like a patient satisfaction scan, and I scan the chromium, I scan the tuberosity, and I make them make the movement, and I show them, wow, it's actually, you have quite a lot of space. Well, it's moving very well. You know, you can enhance the placebo a bit, and then they get really motivated to do their exercises again. Yeah.
And I mean, now that we're talking about it, a question that you knew was coming is how do you deal with asymptomatic findings? I mean, now knowing what we know now, with like a high number, especially as we age, of asymptomatic findings, how do you deal with that, and how do you convey this information to a patient, maybe even before you do a scan?
Well, in some cases you can strongly debate if you should use ultrasound or not. And in other cases, I think it can be very helpful in your differential diagnosis, and therefore also in the choice of treatment. I think it's good to do it in 2 examples. Well, the first one would be, for instance, a patient that comes in with a painful Achilles tendon. There's a typical overuse in the history. You can have some morning stiffness, for instance, and there's no trauma. So, yeah, if you look at your clinical diagnosis, I don't think you need an ultrasound to, you know, make the diagnosis of an Achilles tendinopathy. It's clear. It's very clear. You have like a 95% or even higher, I would say, certainty. But where it gets more difficult is, for instance, areas like the hip. Hip and groin related pain. When you take, for instance, a middle-aged runner that has some diffuse pain, you know, around the lateral hip and also a bit in the groin, and it's a bit all over the place, and you know, then with your clinical tests, you can also have sometimes have some mixed messages, and then you think like, okay, so it's lateral, but it's also in the groin. So would it be lateral tendons? Perhaps would it be GTPS, or could this be more of a joint issue? And then for me, a very simple scan would be to scan the hip joint from the front. You can make a very nice image, and you can see if there is a fluid inside of the joint or not. And I think if I make the scan and I see there is no joint fluid whatsoever inside the joint, then you can pretty much, I think, exclude that there's any intra-articular problem. Because if there would be any intra-articular problem, you would see at least some fluid within the ventral recess of the hip. And then your working hypothesis or a diagnosis for the patient would be to work more with the lateral hip pain and see if problems can be resolved in that way. So I think in those kind of cases, it would be more clear cut, and it would change your management.
Okay. And we already dove a little bit deeper than I thought we would with my questions. Do you maybe have any specific success stories that come to mind where, in your case, ultrasound played a crucial role? Because now we said, okay, it's really good to also, on the one side, it improves your differential diagnosis. On the other side, it's also really useful to exclude things that we don't want to see. And also, we said that especially if it changes management, then it's really of added value, because if it doesn't change management, you could maybe argue, okay, then why do it? Are there any specific success stories that come to mind?
Well, yeah, I have loads of stories. For instance, I've had physios finding some nasty tumors with ultrasound that were not detected. If you want to be crucial, they were perhaps life-saving because they could start treatment earlier. Yeah. But that's quite a unique case, I think. Other cases could be when things from outside the body go inside the body. We call that in ultrasound terms, what's it called again? Foreign bodies. That's the official terminology used in ultrasound. And there's quite some interesting cases that have come by over the years. For instance, one was with somebody that went on a summer holiday that jumped into the sea, and with his foot he struck the coral reef. And then he went back home. He kept having pain in his foot, and everybody was thinking it's exactly on the location of the plantar fasciopathy. They thought this is a plantar fasciopathy. This is a plantar fasciopathy. No imaging was done. He was being sent from physio to physio, and then he came in the clinic with a colleague of mine. And he made the scan. He saw a piece of coral reef actually in the fat pad within the capitum. So that was constantly pressing on it. Another case that I had was a lady that had a fall. She had a pip joint luxation. She had a very red and swollen finger, and I had to mobilize her. So the doctor said, we give her a splint, and then we start mobilizing the finger towards extension. But I was mobilizing her, and she was constantly in very much pain, and it kept being red and swollen, and I didn't know what it was. And I put my ultrasound scanner on, and I saw this very strange structure within the dorsal capsule, which actually turned out to be a small glass splinter that went into her finger when she fell. So every time I was mobilizing the finger, I was, aggravating the symptoms, and therefore I could refer her and get the adequate treatment. So those are quite unique, I think. One perhaps more common. But more common would be, for instance, some cysts that can give complaints. I had a runner once that had cramps in her lower leg every time when she started running. After like 1 or 2 kilometers, she would get this extreme cramps within her calf muscles. So she came in, I scanned the calf muscles, there was nothing to be seen, and I went a bit higher up, and we saw that she had a big Baker cyst, which usually it's fine, it stays superficial to all the tendon or all the bones and the tendons, but this one went deep, and it went towards the popliteal artery and the vein. So you could see they were right next to each other on the ultrasound image. So my theory was that every time she went running, you pump a little bit of fluid inside the Baker cyst, it grows, and it started, causing the pain in the lower leg. And I saw in the literature that if that goes untreated, it could actually, the cyst can actually grow inside an artery or into a vein. So I sent her off for a surgery in that case. Yeah. Or paralabral cysts within the shoulder. Those usually go unnoticed. People usually don't have a lot of pain, but they have some loss of strength. So usually they're referred to you like, oh, there's a little bit of extra rotation, loss of strength. Can you scan the infraspinatus tendon? And you scan the tendon, there's nothing wrong, and the muscle looks fine. But then you go a bit further towards the dorsal side of the humeral joint, and you see a big cyst that can, apply pressure to the suprascapular nerve, which innervates the infraspinatus muscle. And therefore, if that goes untreated, also that can cause complete fatty atrophy of the infraspinatus after a year. So that's also something that you at least monitor it, and perhaps, at least get a surgeon or a sports doctor involved to monitor this process. Because if it's a young person, you don't want this person to completely lose the muscle belly, if possible. Yeah,
interesting stuff. And going back a question, because now we talked about really specific situations. Yep. What are the conditions and injuries that can most effectively be diagnosed using ultrasound? I guess, tendinopathy, we already touched on that. Is there anything else? How good are we, for example, at looking at muscle tears? You mentioned that MRI might be better in those cases, but what else besides tendon would you scan on a regular basis?
Yeah. So, for instance, for the shoulder, you can look at. Usually, it's not very clear what's the exact cause of the pain within the shoulder. There are some things, though. I think if you look at the Dutch new shoulder guideline for the general practitioners, in there you can see that they make a differentiation between, in they call it rotator cuff related shoulder pain. I think internationally in the Netherlands we have a different name for it, but it's like it's not really known what the cause of the pain is. But they make a specific exception for instance, the calcification.
Yeah.
And they say that calcification needs a different type of treatment than when you just have, rotator cuff related shoulder pain. I don't think they mention exactly what cutoff points a calcification is relevant or not, but we looked at some correlation studies trying to find some answer to this, and we found that once a calcification has become like around 1.5 centimeters or larger, there's a very strong correlation with shoulder pain. So we here say that if it's 1.5 centimeters or larger, try to think about sending for a barbotage or sending to the surgeon, because probably with your regular therapy, with exercise, you're not gonna resolve the problem. So that could be a common one. And for instance, for muscles, you asked before, it can be very useful for muscle tears. It does really depend on the operator, though, like I said before. So if you have to have a good operator and, of course, a decent device, not one that's 15 years or older. But you would think that for all muscles it would be great. But if you look at the literature, you have to know your literature as well, because, for instance, the soleus muscle, it is awful. Ultrasound is horrible. It's like a 30% sensitivity and specificity or something like that. Meanwhile, for the gastrocnemius muscle, which is more superficial, it's great. And for the plantaris tendon and things like this, it's a very high diagnostic accuracy. So, for instance, for muscle tears, you could use it, but knowing for which muscle tears, it's not so good. Yeah.
Yeah. All right. Moving on. We touched a little bit on asymptomatic findings. What could be possible disadvantages of using ultrasound, especially to a patient, for example? Yeah,
nocebo. It's a big one. If you do, if you overly focus on structures, for instance, that could be a problem. And sometimes. There's some research done by Simon Hakkebord, who's a Dutch physio, he looked at the perceptions of physiotherapists and their patients. So he made couples in a qualitative study, their perceptions of how they perceive their recovery. And it was very interesting because there were also some physios that did ultrasound in that study. And for instance, one of the physios explained that he made a scan with an elderly lady of her shoulder, and he just saw some, he reported it, just some degenerative changes, which is just some degeneration of the cuff, which is age-related, nothing spectacular. And we don't know exactly how he told it to the patient, but he thought, well, I just explained that, and it's not torn, but, there is some stuff going on. And then they had the perception of the patient, and the lady said, well, my physio said that the tendon was not torn, but it looked very messy, and it was age-related. So now I'm very concerned because I'm getting older, is it going to go into my other joints? And what about my husband? He's 5 years older, so with him it must be worse. Can we still travel? So she extrapolated a lot of information from this. So a nocebo is something to really take care of. And sometimes you think I explain things very clearly, but like what I like to do is to do the teach-back method. Maybe you know it. So next time the patient comes in, ask them. So we talked about the scan and the findings. Can you tell me what I told you? And you will be surprised sometimes at the things they come up with and the theories that they deduct from your findings in the ultrasound. And that can create a lot of problems, I think. So it's good to tackle them with the teach-back method, and sometimes even doing it 2 or 3 times, the teach-back, because keep repeating it and keep repeating the good messages. So the nocebo is big, and then on the other hand, sometimes you try to do your perfect wording, take very good care, and it goes completely the different direction. The example I have is one of my colleagues, Wibbo. He had a patient coming in, an elderly lady, and they asked him to scan the shoulder. But this was a lady of like 80 plus. So there was no clear question what he had to look at. But he was already with the patient in the room. He's like, oh, what do I do? Well, so he made the scan and he saw that there was a cuff arthropathy. So that the supraspinatus was torn, the infraspinatus was torn, the head was moved up cranially, it was touching the acromion. So, and he was like, oh man, now I have to explain all of this to the patient, and not create a nocebo. So he was doing his utter best to explain it. And then he said after it, okay, so do you understand what I mean, or do you have any more questions? And then the lady said, well, yeah, I have one more question. So is it a bursitis or is it not a bursitis? And he said, no, it's not a bursitis. He said, luckily, because I heard that bursitis can take a long time to recover from. And then I think the message from that would be to say, okay, before the patient comes in, try to, as good as you can, find out what they are expecting from you. Because this lady just wanted to know if there was a bursitis or not. And and then you go off, explaining all these kind of things. And so that's an interesting one. And sometimes you take very good care, you don't want to use the word tear. It's very dangerous, the word tear. Once you use the word tear, the patient's going to crumble down and be complete misery. But I've had quite a lot of patients that, well, that's good to know. So what do I do about it? But they were happy that they had the diagnosis. And they didn't care, because I tell them, well, you can perfectly function with, that's good to know. So it's torn, I can work with it. So tell me what to do. So there's also those kind of patients. It depends a bit on the profile of the patient, I think.
Yeah, I fully agree. Yeah. And if I was to start using ultrasound as a physio, what would be typical pitfalls that you would advise that I should prevent?
No, well, first of all is, of course, that you don't scan enough. So to get proficient, like I said, you have to arrange some feedback, supervision on your scans. You have to make sure that you scan a lot. So if you scan only 2 or 3 patients per week, it's not going anywhere. You better not do it. So make sure that you get enough patients to get good at it, or at least practice with people that don't have complaints, but you can practice your scans. So that's a big pitfall. And from the clinic perspective, I think I have some nice stories to tell about when things go wrong. For instance, I have another example of one of my colleagues. He worked at a physiotherapy clinic together with sports physicians, and they worked with a lot of high-level athletes. And he was in his room with his ultrasound device, and he just finished off with his patient. And then a colleague comes in with an athlete saying, look, can you please make a quick scan to scan his hamstrings if there's anything torn? And he had about 5 minutes to go to his next patient. So he said, okay, let me take a quick look. So he looked at the hamstring muscles, and he didn't see anything wrong. And he said, no, I don't think there's anything wrong. So the guy went out, his patient was happy, etc. And then 2 weeks later, he was called in by the sports physician into his room. And the physician said, look, did you scan this patient? And he said, yeah, why? He said, how could you have missed that deep venous thrombosis, the DVT? Yeah. How could you have missed that? And he said, DVT? He said, wait a minute. I was just asked to take a quick peek at the muscles. But if you would have taken the full time, like the 25 minutes usually what you have in the physiotherapy clinic, to do the scan, to ask questions, he would have probably come to the conclusion, wait a minute, there's something fishy here. And he would have gone onto that path. But now he was sort of like blamed that he didn't see the thrombosis. So the take-home message from this one is, take your time to do the scan. And we as physios, we don't just scan. Like I said, we combine it. We combine it even during the scan. You do your clinical tests. You do a scan. You do a test. Does it hurt when I press here? So you're constantly clinically reasoning while doing the scan. Meanwhile, in the hospital, usually what happens is the people just take the scans and you're off. So I think that's an important pitfall. And another one that I can give to your listeners is that always make a good ultrasound report. If you don't do good reporting, things can go wrong. Another example is one of my students. He made a scan of a shoulder, and it was a shoulder with also a cuff arthropathy, right? So supraspinatus gone, infraspinatus gone. He saw some signs of osteophytes, and he was like, okay, I just want to get a better view of this shoulder to know what I'm working with. So he referred to the hospital for further imaging through the general practitioner. And what he had told the patient during the exam, he told the patient that there's nothing there anymore, meaning like the tendons, they are gone. Yeah. He did not send a report. Patient went to the hospital, and in the hospital they started scanning. And then they asked the patient, so what did the physio see? He said, and the patient said, no, he didn't see nothing. There was nothing wrong. And they were like, how could he have not seen that this is completely torn? There's many things wrong. And the take-home message would be, take care that you do good reporting and don't let the patient tell the story to the other clinicians, I think. Yeah.
Okay. Hey, moving on, we already talked a little bit about how many images one should do to become proficient. Do we know anything about studies that take a look at inter-radar reliability of ultrasound? So if you do, I think you're probably very proficient in scanning, and someone else does it of your team. How good would you guys be?
Within my team, I think there would be, I would say there's very high reliability. How am I not going to say that? No, but but in the general population, the problem is that a lot of people are still learning the skill, and there, things might not be as good as you hope. I think for an Achilles tendinopathy, I think there will be pretty high. Oh, you've done the scanning of the Achilles tendon. It's not very difficult, seeing a tendinopathy there. You or me would even get probably a high reliability. Meanwhile, for shoulder tendons, like I said, you need about 150 scans to get really proficient at it. But there's a lot of people still in the clinic in their learning curve scanning shoulders, and that are not that good. So
it's hard to say exact numbers. Yeah.
Okay. Do we have any studies on people that are considered to be proficient?
So there was a study done in the Netherlands, I think quite some years ago, when I was just starting out as a physiosonographer, where they compared scanning the shoulder between physiotherapists and radiologists. And I think that the radiologists had a lot better reliability than the physiotherapists. But that's a pretty old study where I think the physiotherapists were still, in the innovation curve of the ultrasound. So they were still learning quite a few things. And the ultrasound devices that were used, I mean, what you get nowadays, and I think the study was around 12 years ago or 13 years ago, the devices have become so much better. So I'm not aware of any new studies, but I will take a look for you because I didn't do my homework for this one. I'll take a look if I can find something for you, and you can send it to your listeners.
Yeah, we'll pack in a transcript. That's actually a good transfer to the next question that I have, and that's are there any new developments? I mean, we already talked a little bit about improvements in technology. Are there new developments or innovations in ultrasound technology that you are most excited about for the field of physio? So is there any big change coming up right now?
Really excited about. Not so much, at least when I talk to about elastography. Elastography is quite a new application where you can put the probe on the patient, and with normal elastography you press a bit down on the patient, and while you do this pressing on your ultrasound image, you will get a color code, and the color code will indicate how much you can we'll say something about the how do you say this in English, the stiffness. That's the word, the stiffness of the tissues. And it looked very promising in the beginning, but it's very operator dependent on how much pressure you give. And then there's a new development, and it's called shear wave elastography, and they took out the pressure part, and you get the same image, but it's not dependent anymore on the amount of pressure that you give. But at the moment, I see a lot of mixed results coming out. Some studies show, for instance, I think in patellar tendinopathy, that patients get stiffer tendons. I was at a conference a couple of years ago, and they said there were 2 studies showing that with shear wave, the tendons get stiffer, and there were 2 studies saying the opposite. So they were completely against each other. I don't know how the current literature is, but and the shear wave elastography, you can only get it from devices usually from around 60,000 euros and higher. So typically you don't find it in the physiotherapy clinic, but it's something, it might develop into something, but I don't really see the added value yet. Meanwhile, some people are very fond of it and very crazy about it. I'm still a bit apprehensive. And I think what I am very enthusiastic about, it would be AI, which is of course everywhere nowadays, but also within physiotherapy, or if within ultrasound. You can see, for instance, now there's already a device on the market where you scan the patient and it colors your ultrasound image, and it shows this is your muscle and this is your subcutaneous fat, and this, so it fills in the image for you with all the tissues. So that's a very helpful tool. It's not working perfectly yet. I think they still have to work on it, but it's getting there. So that will be very helpful if you want to learn ultrasound, because basically it will tell you what you are looking at, which is amazing. But more interesting would be even the next step. For instance, with thyroid ultrasound, they already have AI models where while you are scanning, live scanning the thyroid, it will put little squares around areas that look suspicious, and it will even give it a color code and a percentage of, possibility of a diagnosis. And that's pretty amazing. So AI will be very helpful, especially for if you're not trained yet in the beginning, to help you guide your diagnosis. But I think for musculoskeletal, I've not seen this yet.
But for the thyroid, for instance, and the liver, I think they've developed some things like this. That would be great to have tools like that for learning the skill. Yeah,
probably a matter of time. I mean, it's basically unavoidable. Yeah.
Yeah.
And we're slowly coming towards the end of the podcast, and I would like to ask you for all the listeners out there who are interested in learning more about ultrasound imaging, what would be your 3 top arguments to learn ultrasound as a physio?
Yeah, the top 3 arguments. The first one, like I said before, you get better at your differential diagnosis. So, especially for ruling out certain pathologies, that can be helpful. Another argument would be to increase your anatomy knowledge. I think I had some perceptions about where muscles are, how long muscles are, how thick they were, and that completely changed when I started doing ultrasound. And I love especially the people that come for the first day in the basic course. You know, the exact reaction that I had back then. They're like, "Oh, it's this big," and wow, it's that large. Yeah. It's their perception completely changed, and I still see it every day with the people here in the clinic. So that's pretty cool. The added value would be, I think, like I said, you get a lot of extra credibility towards your patients, and this credibility can help them to change their illness beliefs. And I think that's a big one. You can really, once you put the scanner on, they trust you. Even if you don't know what you're looking at, the patient's going to trust you. And we have to take care that we don't misuse that, but I think it's good that we use it to change their illness beliefs, and I think it really strengthens the therapeutic alliance. You know, once they really trust you, they get the therapeutic alliance, and you tell them to exercise, and they will exercise. Meanwhile, if they still have this doubt, could it still be a tumor, or could it be something like this? That's a big one, I think.
Yeah, I can see that. Yeah, thank you. And hey, all right, we are coming towards the end of the podcast, and I ask all of the guests, is there anything that we haven't touched on yet that you would like to talk about or to add to the podcast?
We spoke about quite a few things. I could talk about it for all day. Maybe if you're thinking this guy is trying to paint too rosy of a picture, I'd like to give perhaps a little warning, you know, if you want to start with ultrasound, because to use it properly, you really have to put in a lot of work. You have to do courses, you have to arrange supervision, and if you don't do it enough, and I see this constantly happening where people take our basic ultrasound course, they do 2-3 scans a week, and 2 years later they're still not proficient. You know, their learning curve is not going up. So if you do this, take it serious. Invest money and time into your development, in your skills, and I think there's a beautiful quote. I will end with the quote, which is from a legend within MSK Ultrasound. We have Mr. Martinoli and Mr. Bianchi. Those two produced a book, and that's still our Bible. And Mr. Bianchi was once on a conference, and on the conference there was somebody in the audience that asked him a question, and he asked Mr. Bianchi, with all your years of experience, can you tell us please what makes a good sonographer? You know, what does it take? Does it have to be a doctor? Does it have to be a physio? Does it the time they spent? His answer was, he was an Italian with an Italian accent. He said, it's very simple. It's just 2 things. He says, 1, you got to love it. And 2 is practice, practice, practice. So I completely agree with his perception that those are 2 things. You need to like it, because if you like it, it's easy to practice, you know? And if you don't like it, it's going to be a hard learning curve, I think. Yeah.
Okay, yeah, great stuff. I think that's a good end note. And at last, where can people find you if they want to know more about you, or get in touch, or possibly attend some of the trainings that you guys offer?
Yeah. We don't offer courses in the Netherlands in English. We do have an English course that we've given in Israel 2 times now.
but now that's a bit difficult this year. But we have a completely ready course. If anybody wants it, just give me a message. The best thing to reach me, I think, would be LinkedIn. You just go to my name, Niek Vink. I'm also on X with Niek_NTE. But I don't look on X as much anymore. So LinkedIn would be the best way, I guess.
Okay. Hey, and with this being said, Niek, thank you so much for your time and for your knowledge. And it was a pleasure to have you on and talk to you after quite a while. And also, thanks a lot for everyone listening out there to this episode. And as always, to access the transcript and additional resources, make sure to download our new and free Physiotutors app and benefit from more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with that being said, this was Kai for Physiotutors. Until next time, bye.